Hello, good afternoon, everyone. I'd like to welcome us to this session this afternoon. First of all, I'd like to thank everyone who has endeavored to spare time to be part of this. And I would like to thank all the team, the technical team that is invisible to you, who are making sure that you're able to see us and hear us, and who will make sure that we're able to hear you and see you. And also the team that is here to share the knowledge. I thank all of us. I would also like to thank, in a special way, to thank Seed Global Health for giving us the opportunity to meet like this, coming up with the idea and then also implementing it and sustaining it. Thank you so much. At this point, I would like us to move forward, and I would like us, first of all, to make God part of this session. And like in Proverbs 16:9, the Bible says, we have so many plans in us, but it's only God who establishes all of them. So I would like us, to, first of all, to invite God into this session. And I would like to request Mr. Andrew to lead us with an opening prayer. Thank you.
Thank you very much, our moderator. Let's have ourselves by prayer. Lord God, King of Kings, we thank you. We bless you. We thank you for the time you've given us. We ask you for guidance in this session we're going to have. Give us the direction, and so that whatever we're going to talk about and learn, it gives you praise and proclaims your name. We ask all this through Christ our Lord. Thank you.
Thank you so much, Mr. Andrew. Yeah, like I've told you already, that we are here to share knowledge. And before we go any far, I would like you to know my name. I am Dr. Lukot Moses Donald, and I'm not here alone. I'm with a team whom I'm going to request to introduce themselves. My role here is to moderate. And so we are going to move from my right to my left as we introduce ourselves. Thank you. Yeah.
Thank you very much, Dr. Olupot. My name is Nora Nabakala. I'm a junior house officer at Kawempe National Referral, currently rotating in pediatrics. I'm glad to be part of the team that is going to dissect the topic of respiratory distress syndrome today. Thank you all.
Thank you. Yeah.
Thank you. Good afternoon, everyone. I'm Kezia Shibedi. I'm a pediatrician working with Mulago Specialized Women and Neonatal Hospital. I'm very blessed and humbled to be here. Thank you.
Thank you, Dr. Kezia.
Thank you very much. I'm Lieutenant Andrew Tumime. I am a pediatric nurse. I work with Joint Staff Health Services, Uganda People's Defense Forces, and I'm glad to be here.
Thank you so much, Mr. Andrew. Yeah, so I'm glad to inform you that there's one of our members who is calling in online. Part of the team is present here physically, and then part of the team is calling in online. So I'm going to request one of our team members to unmute and then introduce himself.
Yeah, thank you very much, moderator. Good afternoon, colleagues and participants online. Dr. Tom Mediam is my name. I'm a senior consultant pediatrician and neonatologist attached to Moroto Regional Referral Hospital. You're almost welcome. Thank you.
Thank you so much, Dr. Tom. Yeah, so I would like us to feel at home as we discuss. This is a platform to share ideas, to share knowledge, feel at home. And I would like to introduce our topic. This is our HOPE session. HOPE means Hearts of Birth. So perinatal and neonatal Hearts of Birth, session number 8. And in this session, we are looking at respiratory distress. And to look at respiratory distress, we know respiratory distress is a problem that affects everybody. It affects adults, it affects the old, it affects women, it affects everyone. But today, what has brought us here is to look at how this problem affects a newborn baby. And by talking about a newborn baby, I'm actually meaning a baby who is less than 1 month old. In medical language, you call that baby a neonate. So 1 month may vary from one person to another, but we know that it can either be 28 days, 29 days, 30 days, or 31 days. So you can have, we probably would, clarify more on that later. Yes, so respiratory distress in a newborn has so many factors causing it. And in this discussion, we are going to cover 5 key objectives. And one of these objectives is respiratory distress syndrome, and then transient tachypnea of the newborn, and pneumonia, and then meconium aspiration syndrome, and finally, apnea of prematurity. So those are the 5 key conditions that we have selected, but it doesn't mean to say that those are the only conditions that cause respiratory distress. But these are the commonest conditions that we see in our wards. As we discuss more, hopefully our experts will, maybe if time allows, bring in a lot more information regarding the conditions that are responsible for respiratory distress. But for now, for this discussion, we are outlining those 5. And it's important for us to know the different, what makes up a newborn? What makes up a newborn? We know that in newborns, we have prematures and then term babies. So we have to understand that difference as we go into this discussion. Because sometimes there are questions that arise and ask, is a premature also a newborn baby? The answer is yes. A premature baby is a newborn baby. The difference is that a premature baby is a baby that is born before completing 37 weeks in the womb. And then a term baby is the baby that is born after completing 37 weeks, or, after completing 37 weeks. So that's the difference. But as long as the baby is born and that baby is living and is less than 1 month old, that baby is a newborn baby. So you can then look at things like abortion and the rest, but we are not going to bring that into this discussion. So with that preamble, with that foundational information, I would like us to delve deeper into the discussion. And before we go into the case presentation, I would like you to know that there are questions before and questions after the discussion. So I would like those questions to be projected, and I would like to invite all of you to attempt them, answer them, because they are important. It helps us to assess your understanding as we share the knowledge. Thank you so much. So you will allow me to invite Dr. Nora to give us her case presentation as you respond to those questions. Thank you. Yeah, you're welcome, Doctor.
Thank you very much, Dr. Olupot, for that preamble. As previously introduced myself, I'm Nora, an intern doctor from Kawan National Referral Hospital. Today, I will be presenting a case that will guide our discussion in the management of respiratory distress in a newborn. And I'm very much certain that most of us have encountered newborn baby, and maybe some of us do not know what to do when our baby has fast breathing, chest indrawing. So this is going to sort of like paint a picture of maybe that baby you have encountered before in your health facility, or at any time somewhere there, maybe in Ginger. And yes, it will guide our discussion today. So this is a case of baby of AJ that was born on the 6th of November 2025, a female. Currently, that would be like 8 days old. Baby was born from Kawempe National Referral Hospital, and the mother came from Bunamwaya. So the baby presented with difficulty in breathing, and this was a preterm baby. So when we received this baby, it was a 1 hour old baby born at 28 weeks of amenorrhea, with a birth weight of 1.2 kilograms. This baby was born to a 16-year-old at 16-12 hours by emergency cesarean section due to preeclampsia with severe features and intrauterine growth restriction that was based on an ultrasound scan. The APGAR was 6 at 1 minute and 8 at 5 minutes respectively. This baby in the labor suite theater was resuscitated with bag and mask ventilation, given dextrose 10% and normal saline. On arrival, baby was brought in, wrapped in small sheets with nasal prongs in situ on 1 liter of oxygen, and was brought in a baby carrier. So in taking further history, the mother reported that she had drainage of non-foul smelling colorless liquor for 22 hours prior to the delivery. So this is a 16-year-old mother that is a para 1+0. She had 2 antenatal contacts. And the first one was at 21 weeks of amenorrhea from Bunamwaya Health Center 4. And while there, she was given hematinics, that is PEPO, and she was only tested for HIV and syphilis, which were negative. She reported no known chronic illness such as hypertension, diabetes, and she did not smoke or use any alcohol during the pregnancy. At 24 weeks, that was the second antenatal contact, she was diagnosed with preeclampsia with no severe features due to the high blood pressures. And there, she was started on antihypertensives, methyl-dopa and nifedipine. However, at 28 weeks when she came in on admission, she presented with epigastric pain and blood vision, and this had been there for 2 days. The blood pressures were still high, so a diagnosis of preeclampsia with severe features was made. And part of the management plan, mother received dexamethasone and magnesium sulfate while on the preeclampsia ward. On examination of the baby, it was a tiny infant that was in obvious respiratory distress, hypothermic with an axillary temperature of 35.9. They were pink. There were no obvious dysmorphic features, no pallor, jaundice, or dehydration. Using the Ballard score, we estimated the gestation age to be 26 weeks. On the respiratory system, the baby was in severe respiratory distress with a Silverman-Anderson score of 8/10. They were tachypnic with a respiratory rate of 68 cycles per minute. Generally, the baby had normal chest shape. The SpO2, the oxygen saturation on free flow oxygen was 75%. However, when the baby was put on continuous positive airway pressure, the oxygen saturation improved to 96%. And there was bilateral air entry on auscultation with bronchovascular breakdowns. In the cardiovascular system, notably, baby had both peripheries, pulse rate of 145 beats per minute that was regular, of normal volume, and synchronous. And also, heart sounds 1 and 2 are present with no added sounds. And on the abdomen examination, the abdomen was of normal fullness, the cord was fresh and clean, well tied, with no obvious oozing of blood. And the abdomen was also soft, non-tender, with no palpable organomegalies. And on the central nervous system examination, this baby was alert, actively moving all limbs with normal tone, and the anterior fontanelle was normotensive. However, the baby had a poor suck, grasp, and moral reflex. So then on admission, our problem is we had a preterm that was hypothermic with respiratory distress and of very low birth weight. So then our impression was 1 hour preterm neonate of very low birth weight with respiratory distress syndrome at a risk of neonatal sepsis, given the fact that there was prolonged rupture of membranes prior to the actual delivery of the baby. So in our management, on the primary survey, of course, we ensured the air was patent, any visible secretions were suctioned using a penguin sucker. And this baby, remember, initially came on free flow oxygen. We put them on bubble CPAP, and the oxygen levels are at 10 liters, and also established intravenous access, gave a bolus of betaine in addition to what had been given, and also normal saline. When we did the random blood sugar, it was 7 millimoles per liter. And since the baby was hypothermic, we also put her under a warmer. So part of our treatment plan was to start this baby on first-line antibiotics, that's ampicillin, gentamicin, and calculated the total fluid intake at 80 mils per kilogram, and the baby was to be on nil per os and only be given D10. So every hour, the baby was to receive 4 mils. And in plan, we had to administer surfactant, 5 mils, we're giving at 4 mils per kilogram, and also look out for septic markers, that's the CBC, and also ensure that, look out for the renal function test, the liver function test as well. So on day 1, baby had minimally improved. So their temperature had improved to 35.4. However, on CPAP, they were desaturating, and now the oxygen saturation was 60% with a pulse rate of 128 beats per minute. So the baby was noticed to have stopped breathing. On examination, baby had secretions in the mouth that was suctioned. We initiated bag and mask ventilation. Baby gave loading dose of caffeine citrate at 20 milligrams per kg, gave a bolus of normal saline and D10, and within 5 minutes, the baby's oxygen saturation had improved to 94%. So the plan was to put this baby on electric CPAP with a PEEP of 8 centimeters of water, and also administered surfactant, and were to monitor the vitals every 30 minutes until stable. On day 2, still had the same impression, and baby now was back on with an oxygen saturation of 96% on electric CPAP. The respiratory rate had gone down to 60 cycles per minute. Temperature was now normal, 36.6. And also the respiratory distress was minimally improving with now a SAS of 6. So we maintained the caffeine citrate at 10 milligrams per kg, and also inserted an NG tube for feeding since this baby was still in respiratory distress. So we did not want the mother to breastfeed, as this would put them at a risk of aspiration. On day 3, the labs were noted, and the baby had a neutrophilic leukocytosis with a very elevated CRP, more than 10 times the upper limit. However, the electrolytes and the RFTs plus LFTs were all within normal ranges. On that 3rd day, on examination, baby had actually deteriorated a bit, and they were sick looking now, febrile, with an axillary temperature of 37.8, still in distress. However, still there was no pallor, jaundice, or dehydration. The respiratory rate was at 50 cycles per minute, and the oxygen saturation was at 95% on CPAP, electric CPAP. So we switched the baby from the 1st-line antibiotics to 2nd line, that is cefotaxime and amikacin, and we plan to do a blood culture, initiated express breast milk at 3 ml 2 hourly, in addition to the neonatal cocktail. So on day 5, baby was in fair general condition, febrile, and the distress had actually improved. And the Silverman-Anderson score was now at 4. Still no jaundice, pallor, or dehydration. And then the SpO2 was at 97% on electric CPAP, pulse rate. All the vitals were within normal. And as I speak now, the baby is still on the ward, actively being managed, however, with great improvement. Thank you so much for this.
Thank you so much, Dr. Nora, for that beautiful presentation. Yeah, so I think we've been all listening actively, and the case feels familiar now. And we are delving now into discussing it. If you have any questions, they are welcome. If you have any questions regarding the presentation or anything that you would like us to clarify on, you are free to bring it up. Yeah, so just put up your hand and we will thank you.
This is James Gitai.
Gitai,
I think
you're free to speak.
Yeah, thank you very much, Nora, for your presentation. I noted you administered the surfactant on day 1. I just wanted you to clarify what dose of surfactant, how many doses of surfactant you received, and what was the approach of administration? Because I realized on the other days you don't mention about surfactant. Thank you.
Thank you so much, James. Another hand is up. Edbert Bagasha, you're free to speak.
Thank you very much. Appreciate Dr. Nora for the presentation. I have an inquiry about the SARS score, because you mentioned that admission, the patient was scoring 8 out of 10, which usually that is under the severe form, and it's likely they go straight for intubation. How come we began with CPAP? Should have been for the moderate.
Thank you so much, Edbert. Your question is noted. Dorcas, Dorcas Ahoneza. If you're there, you can, if you have, we invite any question. If you have any, please. Dorcas?
Sorry, I have no question as per now. That could have been an error.
All right. Thank you. Which Christine Enjaru. Christine Enjaru. Yes, Christine. Yes. Tell me if it. Christine. Christine. Okay. Okay. Stay. Okay, Moses Asimwe.
Okay, thank you for your presentation. My inquiry is on antibiotics after switching from the ampicillin and Genta to amikacin and cefotaxime. So, like, are we supposed to? My inquiry is I need some clarity on use of cefotaxime alone and amikacin, or we use both together.
Thank you so much, Moses. Asiredina. She's not on.
Thank you so much. Thank you so much for the presentation, Dr. Nora. Mine is on CPAP. The baby was put on free flow oxygen, then shifted to CPAP, then electrical CPAP. I just want to know how electro CPAP looks like and how it works. Thank you.
Thank you so much for that question. Yeah, I think we will come to those questions. Should we respond straight away? Okay, so let me invite Dr. Nora to respond to.
Thank you so much for the questions, very important questions that you asked there. So I'll start off with the question that was asked about the dose of surfactant that we gave. So we gave surfactant at 4 mils per kilogram because we were using a brand called Savanta and usually administer it at 4 mils per kilogram. And you also asked about the mode of how we deliver the surfactant, something I wanted you to think about, but anyway, I'll just answer it. So surfactant is administered intratracheally as per now. However, still there are some research that is going on to make it less minimally invasive. Yeah. Then Dr. Bagasha, who asked, the baby came in, right, with a SARS score of 8/10, which is that's severe respiratory distress, and usually that's an indication to intubate the baby. But given that, as you know, we have limited ventilators, so we usually first put these babies on continuous CPAP, yes, and most of them actually improve within like 12, after 48 hours, they usually improve. And if baby does not improve on CPAP, now to answer the next person who is inquiring about the difference between electric CPAP and just a bubble CPAP, that's I think the expert will talk more about that. But what you should know is that on an electric CPAP, you actually can control the PEEP that you give. You can either there's a range of PEEP. So an electric CPAP is believed to be better. But however, and the expert will talk about that, yes. And then about the antibiotics, whether to use cefotaxime alone and amikacin, also didn't want to preempt the discussion ahead. So our expert will talk more about that. However, thank you so much for those important questions raised.
Thank you so much, Dr. Nora, for the response. I believe there's a lot of discussion coming ahead. and most of those queries will be answered. Yeah, let me take this opportunity to invite Mr. Andrew, who is going to take us through nursing care. Thank you.
Thank you very much, our moderator. And thank you very much, Dr. Nora, for that wonderful presentation. Once again, Andrew Tumwine. I'm going to take you through the nursing care plan for the nursing management. So first and foremost, this neonatal respiratory distress syndrome is one of the leading causes of mortality among preterm babies. And usually 50% of these babies develop, mostly 50% of these preterm babies develop neonatal respiratory distress syndrome. And usually those who are less than 8 weeks of gestation suffer the most. And usually in our nursing management, we don't forget that oxygen, and then like we've had from the case, CPAP, as well as in case we can manage to get mechanical ventilation, better. And usually as nurses, let's not forget that our care is going to be patient or caretaker-centered approach. And we should also not forget that we need to use SMART goals to achieve better outcomes. Okay. Basically, we assume that when the patient comes in, definitely we have to do a reassessment. And when we do a reassessment, we check for all those parameters that we find would actually bring any changes. So when we've done our reassessment, we've checked the appearance, we've seen the parameters, we've monitored the SAS, and remember we have also the information that we got from the case, especially the body weight and then the weeks of gestation. We are most likely to get the first nursing diagnosis, our priority nursing diagnosis, as impaired gas exchange. It could be related to alveolar surfactant deficiency or alveolar collapse, and evidenced by that low oxygen saturation that we saw, and again a raised respiratory rate. Okay, that raised respiratory rate because the baby is trying to achieve his or her minute ventilation, so the respiratory rate has to be high. So our intended outcome, basically, we need to make sure that this baby, within a particular period of time, has achieved free flow, and the breathing is normal, has normalized. And then also, how do we do this? We need to maintain our patient. So we need to monitor our patient's SAS, and usually this SAS will guide us on whether to initiate on CPAP or not. So, like the case said, if the SAS score is above 4, so definitely that one drives us to decide that we need to start this patient on a CPAP. And also, there's a question that what if I'm in a low resource setting? What can I do? So I've managed to include a link for our people who may be in a low resource setting, and they just to know how to improvise and create a SAS, create a CPAP using local available materials. So usually, the SAS is going to be our prognostic check to monitor how our patient is faring, and then also we need also to, it will help us, yes, optimize the possible outcomes. And we expect to see that within a stipulated time, the patient is relieved of the distress, the severity is lowering, and our patient is improving. Okay. And then this one also will be guided by the vitals that we shall be getting. Next. Okay. We have included those pictures to give us a representation of how our alveoli are most likely appearing in our patient. So you will observe the picture on the right and the left, and then compare, throw the comments in the comment section, and then we shall be able to see them. Okay, next. Okay, so we have realized that we cannot do away with a CPAP. And what is this CPAP? So basically, this CPAP is a continuous positive airway pressure. You maintain the pressure in the lungs so that the alveoli can keep open. So when the alveolar compliance is achieved, oxygenation is also achieved, and then you are also preventing lung collapse in the long run. So usually in utero, the fetal lungs are maintained at 3 to 4 centimeters of water by that fluid which is contained in the alveolar sacs. But when the baby is born, now that physiology is lost, and now the CPAP has to maintain that pressure to keep the alveolar sacs open. And physiologically, the benefits of CPAP, like we've said, it will improve our oxygenation. It will also keep our fraction of inspired oxygen within the lungs, that air that remains in the lungs after a passive exhalation, to be within normal range of between 17.7 to 31.3 there. And also to improve lung growth, and then it also promotes surfactant production. Thank you. Next. Okay, now to ask the nurses and my fellow nurses in NICU, that CPAP is important. So when you have that patient on CPAP, have at the back of your mind a number of questions. Is the CPAP really correctly placed? So if it's not really, you need to do something, please. So, and again, you need also to ask yourself, is the baby tolerating to this CPAP? Okay, you put your to-do points and make sure you do intervention, please. And then sometimes the CPAP actually could present with complications. If the baby is not tolerating to CPAP, really, say the baby is now getting a distended abdomen, it means instead of helping now, you are actually doing more harm than good. Okay? So when you have a number of those questions, you know that I'm doing well. It's kind of a prognostic check to tell you that you are doing well or you need to do something. It could be a CPAP to manage or to help you, but again, it could as well become a disaster, especially if the baby has been given surfactant like we've had in the case. Okay? Yes, next. Okay. So let us now delve into our second nursing diagnosis, and this is called ineffective breathing pattern. It could actually be related to the pulmonary exhaustion. The baby could be tired. The baby could be in pain, because we normally neglect pain in these neonates, and this could be actually observed or evidenced by the increased work of breathing. If the symptoms are not subsiding, you've managed it, but the symptoms are not really alleviated, then it means the baby is still in pain or is still in need. So usually, you need to improve to maintain the breathing like the baby to breathe well. And how do we do it? Positioning. Simple positioning. And usual positioning in units is really complicated, but you try. You can tilt the head, you can roll the bed sheet, and then make sure that the neck is in a neutral, with an assumed neutral position. Achieve effective ventilation. Okay. So, and usually when you position, then usually you expect to get positive outcomes. Okay? Sometimes if the baby is in need of caffeine, especially if the team has realized that you need to administer caffeine in apnea of prematurity. Remember, these babies are also prematures, they present with apneas. You can administer caffeine, and where I've observed caffeine, we normally confuse it. Someone says I have caffeine base, someone says I have caffeine citrate. So that confusion really, caffeine is important, but you might end up giving too much or too less. So I need to clear the confusion that caffeine citrate is actually times 2 of the caffeine base. If you have 2 milligrams of caffeine citrate, meaning you have 1 milligram of caffeine base. And usually this caffeine it helps in its mechanism of action. It blocks those enzymes, the phosphodiesterase enzymes 1, 2, 3, and 4. And then the smooth muscles in the respiratory system, in the respiratory system will be relaxed, and then bronchodilation will be achieved. And then within a certain period of time, you do a reassessment, and you see that our baby is improving. Okay? And then also you can scale the pain. These units are in pain, but we normally ignore that pain, and we find pain actually is actually worsening the condition. Let us use those scales. We have scales like cries. We have scales like NIPS. If you scale that pain and then you know your patient is at a certain level of pain, you reduce the pain, then you are good to go. It could be a non-pharmacological mechanism or intervention. And actually, I don't want to forget that research has actually gone ahead to say that earlobe massage in these units has actually done well, because it says it reduces the catecholamine levels, and then you end up reducing the pain, and you scale the pain, and you find really your unit is doing well. Okay. So thank you very much. Now on this picture, I need us to think the picture on the right and the picture on the left. The arrow is saying we need to change the picture on the left to appear like the picture on the right. And if you observe, definitely there are certain things you can observe, especially the first picture on the left, then and the second picture, so that we transform them to the other picture, which actually appears well, and throw the comments in the comment section. Thank you. Okay. Now if you've done those, if you've achieved those those interventions and under those 2 nursing diagnoses, means we are doing some good work. However, there could be also a chance that this baby might be suffering from an imbalanced nutrition, less than body requirements. Remember, this baby is premature. The baby has a poor or absent sucking reflex. And by virtue of that, it means and then remember, being a premature, the glucose demands are high. Definitely, you will need to supplement, and then you improve the glucose levels. And the outcome here, the intended outcome, is that you need to make sure that we intend within a certain time to have these babies. First of all, the body weight really. Actually, here we may not rely so much on weight gain, but we can call it weight velocity. The amount of weight that should be added on a baby daily should actually be increasing. 2, if you see our baby, the RBSs are in normal ranges, then you are doing well, and much as you may not realize it, but when you monitor, you find you are doing very well. And usually here, the weight velocity, I've tried to search different sources, say different ranges, but I've put a weight velocity which is general. And also we need to monitor the RBS levels every after 6 hours, much as we need to limit the invasive procedures, but RBS is also equally important, because this neonate is relying on glucose for heat energy. And now that heat energy, if the heat energy is there, the glucose is overutilized, the weight is not going to be gained and will not improve. And we need to have a glucose range between 2.5. 2.5, we are good to go. And then up to around 6.9. In that range, we shall be moving well. Okay. Okay. Now, we managed our case, we managed our patient. If you've done that, really, as a nurse, you're doing fine. But also, there is also risk for hypothermia. This baby, like we said, is exposed. Is exposed to the environment, has a low fat mass. So, and that, remember also the low birth weight that we got in this baby. It really shows that the body is really in demand. So if you don't control the environment, if you don't close those windows in the NICU, the wind, it would actually be doing more harm than good. And usually here, hypothermia, it could worsen actually the condition, because like we said, hypothermia, it means much of the glucose will be broken down for energy, and now the baby is losing so much. So what do we do? Use those warmers in case you have them, and in case you don't have, use the available resources. And in areas where they have those electrified warmers, they have what they call a servo control. That servo control, it is that button that you put on the baby, on the neonate. It will monitor the temperature and regulate the amount of radiation. So please use them. And if you don't have them, use the beddings. Keep the baby warm in bed in warm clothes. Swaddle the baby in those warm clothes. Make sure the baby is dry, and then you keep monitoring the temperatures. Okay, and by the time of a certain time, that certain time that we put is not so specific. It is to gauge you so that you go back, and then you recheck yourself or reassess your so that you don't say I'm managing until when, because you think you're managing and then you have not timed yourself. So you go back and recheck yourself. So you realize that the baby's work of breathing is normalizing, and if it doesn't, it's okay. You recheck and see where did you go wrong, and then you reassess and replan. Okay. So we've seen that low temperature is actually a danger, but also there is also risk for infection. This baby is actually at a risk of infection, based on the invasive procedures we do, based on remember their intake is poor. Expressed breast milk may not be enough. And remember that the breast milk has that secretory immunoglobulin A. Very important. It maintains the GIT surface. The GIT surface is maintained. The integrity is maintained, and also it participates in boosting the body immunity of that baby. And remember, in our case, there was prom of actually more than 18 hours. So our babies, the environment was exposed. So when we are managing these cases as nurses, please, let's maintain a strict hand hygiene. Actually, even the attendants, let them wash hands. If they wash hands, then you're good to go. You are in a safe environment. Put those gloves on. Don't recycle gloves. And as you do that, you are actually reducing on the chances of our babies getting unnecessary infection. Okay. Okay, thank you very much. That was our nursing management. We didn't go step by step, but we had to highlight on most important areas. Thank you very much.
Thank you so much, Mr. Andrew. I think he has been very clear and as detailed as possible. Yes. So it's important in the care of newborn babies, all the things he has counted. Without forgetting, if you don't have access to a warmer, make sure you benefit from kangaroo mother care. There's warmth on the chest of the mother. So if you don't have access to machines, actually, there are many studies that are emphasizing that kangaroo mother care is actually superior to the use of those other warmers and so on. So encourage mothers, because by encouraging them to use kangaroo, you're encouraging continuity. they can do that even at home, because that baby will not be in the hospital all the time. Thank you so much. Thank you so much, Mr. Andrew, once more. If you have any questions, please note them, because we will move to the session of discussion and questions, and you'll be able to raise all those questions and we'll respond. So at this point in time, allow me invite Dr. Kezia to take us through management of a baby with respiratory distress syndrome. Remember, we have 5 objectives. We have picked respiratory distress syndrome as representative because we can't, because of time. But we have all the conditions we have listed, including apnea of prematurity, meconium aspiration syndrome, neonatal pneumonia, TTN, and RDS. All those are present with respiratory distress. So just use this respiratory distress syndrome as a window to explore other conditions. Thank you so much. Doctor, you're welcome.
Thank you. Thank you very much. My work has been made easier because most of the things have been discussed. It's just a reminder and a trigger, since we are all health workers and we have worked and have experience. So I'll go through as fast and as slow as possible. So we are marking the World Prematurity Day 2025 on the 20th, and it will be in Imbarara. And the theme for the year is Give Preterm Babies a Strong Start for a Hopeful Future. So as we go through this discussion, let's think about that preterm. Who needs a strong start? A strong start is in very many dimensions, and some of them we are going to cover them in this discussion. So the objectives are one is approach to a neonate with respiratory distress. So as much as we have the other definitive diagnosis that we are going to discuss, our major focus will be how do we approach a baby with respiratory distress, because it's the common pathway, and at the end of the day, we have respiratory distress. So we aim to recognize and classify respiratory distress, to differentiate the causes, and then to manage effectively at all levels of care. At all levels of care is very important because everyone has to do their duty before we push this baby to the higher centers. So why respiratory distress? Why did we pick this of all the complex diseases that we have? Respiratory distress is a symptom, it's a sign, it's not a diagnosis. And from statistics, it shows that it's the most common symptom leading to neonatal admissions worldwide. And early recognition and timely management can make a difference between either recovery or mortality or morbidity. So every minute of uncorrected hypoxia, and this hypoxia is seen outwardly as respiratory distress, creates a risk to brain injury and death of this neonate. So we need to have a systematic approach, and this pathway is extremely important. The warmth, the airway, breathing, circulation, and then to get the cause of the distress. So the burden in Uganda, up to 30% of the neonatal admissions presented with respiratory distress. Studies done in Mulago, in Imbarara, and in Mbale locally showed that respiratory distress was among the top common causes of admissions and mortality. So that in red, we said that low-cost bubble CPAP programs have reduced this mortality by over 40%. Very important, as the pre-current discussant said, that CPAP is one of the most important interventions that Uganda and the world is really pushing, so that we give the preterms and other babies a strong start. The burden again, globally, we are saying the frequency of respiratory distress is about 5 to 7%. And the common causes are TTN, RDS, and sepsis, which are one of the topics we are discussing. In Africa, Uganda, admissions for distress are mainly RDS, which is prematurity. So when you look at the preterm babies, about 60 to 80% of all the preterm babies present with respiratory distress, and the main causes being RDS and apnea of prematurity. And then for the term and the postterm babies, It's mainly TTN and meconium aspiration syndrome, plus pneumonia, which is usually a late onset. So recognition, how do we recognize that this person is respiratory distress? We know that the normal respiratory rate of a newborn or a neonate is between 40 to 60. So anything above 60 is points to respiratory distress. And when we are counting respiratory rate, we count for 1 minute. Why? Because babies don't breathe at a regular state. They usually have episodes of, that's what they call periodic breathing very fast and then calmly. So we need to count for a whole minute. Respiratory distress, it shows clinically by increased work of breathing. And why does a neonate increase its work of breathing? It's a compensatory mechanism to maintain oxygenation and ventilation. And like we've heard, oxygen is a fuel for life. If there is no oxygenation, then it means we shall die. So the unit will die very soon. So what are the signs? Tachypnea. Tachypnea is increased respiratory rate above 60 breaths per minute. We have grunting, nasal flaring, chest restrictions, head bobbing, cyanosis, and hypoxia. I'm going to look a little bit in detail to tell you how these neonates actually communicate to us. So what is grunting? We know the baby is grunting, and we always say the baby is grunting, but it's that noise that the baby makes at the end of expiration. And it's important because the baby is telling you that, come on, help me out. It means physiologically that the baby is trying to keep that PEEP, that pressure within the alveoli at the end of expiration, because the alveoli can easily collapse, but it's trying to maintain it. So when the baby is grunting, it's telling you, come, help me, put some PEEP in me. That's where our CPAP comes in, to create some PEEP. And when we create some PEEP, it means the functional residual capacity is maintained. And this helps the alveoli not collapse and hence improves oxygenation. So it's an early sign and important sign of alveolar disease. So if it's present and it persists to moderate to severe, then we shall go into respiratory failure. So baby is grunting, act, give the baby the PEEP that they need, using usually CPAP. So next is nasal flaring. Sometimes you just look and you say nasal flaring, but I would say it's the widening of the nostrils during inspiration. And what does this mean? It means the baby is trying to overcome the resistance. And in babies, they are obligate nasal breathers. So if their nostrils are blocked or in some way they are obstructed, then there is an increased resistance. And they say up to 50% of the resistance in the airway, it comes from the nasal passage. So we need to clear it out. So if you clear it out, it improves airflow and improves minute ventilation, which increases inspiratory effort in cases of hypoxia and hypercapnia. So it's a sign of inspiratory effort. I'm trying to breathe in this air. So please come and help me push this air in without exhausting me, okay? So head bobbing. Head bobbing is usually a death sign. And this is the rhythmic movement of the head at every inspiration. And the baby is telling you, I'm getting exhausted. Come and help me out. So it indicates that the diaphragm is insufficient to actually push this air in without a lot of resistance. So the other accessory muscles come into play to help the baby out. So it's a late sign, and it shows it's a severe sign of fatigue and impending failure. So you see a neonate bobbing, we should run very fast. So chest retractions. Unfortunately for us, the neonates and the preterms, our chests are soft. So they easily suck in. And yet, by pathology, because we have a large negative intrathoracic pressure that has to be overcome. So these babies try to suck in this air. Again, it's a very big negative intrathoracic pressure. So it is usually, if we have subcostal and intercostal, it's early sign of distress. When it goes now to the suprasternum or the xiphoid or the sternum, then it's showing you that there is advanced distress and a risk of exhaustion and respiratory failure. So when we have this, because we have to recognize that this baby is actually in distress and we have to act. So we use a structured approach, and in this, we are looking at the history. You take your history, you examine, you investigate, then you interpret and act immediately. Because as much as we are supporting the babies in the respiratory distress, At the back of your mind, you need to know what the underlying cause is. Okay? So in your history taking, when they say, when was the onset? Baby is delivered. When did they start breathing? Very fast. That helps you know. There are some conditions that start immediately and others start later on. You look at the delivery events. What happened? Was the delivery very difficult? Did the mother have any infection? Is the mother diabetic? Was there meconium? Is the baby term or preterm? When you have that history, if there is a 1 point, like our case, the baby was 1.2, you wouldn't want to say meconium aspiration syndrome when the baby was a preterm. Okay, so in the history taking and the examination, it helps you clarify and classify some of these causes. So in the examination, you look at the pattern of breathing. Sometimes, as you experience, when you look at a baby, you will know that this baby actually has upper airway obstruction because of the way they are breathing. Oh, this baby is really usually alveolar. Then you also look at the chest symmetry, like Dr. Nora said, the baby's chest symmetry helps you. In places like meconium aspiration, sometimes the chest can be deformed. Sometimes the air entry is not equal. Sometimes they just physical chest deformity. So in the investigation, some are clinical, just there on spot bedside, like the oxygen saturation is very important. For us who can be able to do the SpO2, we can do, and it will help us speak into our diagnosis. Then we can do the septic screening. Like our baby had actually sepsis. Our therapy was 106. It was really high. And with the history that the mother had of draining of liver for over 22 hours, and the risk of sepsis for us, the standard is that if there is drainage of liver for over 18 hours, then it puts the baby at risk of sepsis. So you interpret what we have, and it will guide you in what the likely underlying cause is. Okay? So we differentiate. Differentiating is knowing the underlying cause. Like I've said, if it's early onset, say for example, meconium aspiration, some cases they start early because they have aspirated and obstructed. Others, the respiratory distress comes on later. Why? Because the meconium will enter in there and then start disrupting the lungs, maybe after 24 hours or 48 hours. That's why sometimes we admit these babies with meconium exposure, even without respiratory distress, because it may come in later on. You look at the risk factors, like I've said, the mode of delivery. For example, in cesarean section, why would cesarean section expose the baby to respiratory distress? We shall see. There are some diagnoses like transient tachypnea of the newborn. One of the risk factors is cesarean section without labor. Okay, and as people become richer, they fashioning cesarean section, it's now fashion. So as you fashion to do cesarean section, you're putting your baby at risk. Okay. So chest X-rays are very important. However, they're not available to everyone. We have circled using silver Anderson score because it's a clinical tool that can be used by everyone, and it speaks lots of volumes to what is happening to the baby and the way of management and the way of looking at the prognosis of these babies with respiratory distress. Yeah, so silver Anderson score. I will talk about it because it's important, because elsewhere, now in places like Magamaga, where I come from, they may not have an X-ray. They may not have these other sophisticated things, but we are saying the health workers can actually use your clinical judgment to actually help this baby. So in the silver Anderson score, you look at 5 parameters, maybe you can 5 parameters, and then you grade. So the parameters are upper chest movement, then the next one is lower chest retractions, xiphoid retractions, nasal flaring, and a grunt. So you grade the baby accordingly. So you add up, and the total would be 10. So it ranges from 0 to 10. And depending where it falls, then it will give you what to put the baby on. One of the questions was, why was the baby put on free flow? I'll answer that question at this point. Why was the baby put on free flow? Yet this baby comes in, 1 is RDS, is a preterm, 1.2, and then 2 has a SAS score of 8. So sometimes we do these cases not because they're standard, but they're learning points. So for this baby who is a 1.2, ideally we should have started with CPAP straight away, regardless of the SAS score. But maybe it was an oversight, or like Dr. Nora said, our systems, Kawempe has more than so many babies, so sometimes we overlook these things. But such a baby would have gone straight away to CPAP. So this Silver Anderson score, you score, and then it guides you onto the next step. So if our score is 0 to 3, then the severity is mild. If it is 4 to 6, it's moderate. If it's 7 to 8, it's severe. And what action do you do? If it's mild, then sometimes you observe, but with preterms or with underlying causes in mind, we can either put on free flow or CPAP. Preterms with RDS or with suspected RDS, before even they go into distress, you start CPAP in labor ward, CPAP in theater, before the babies go into distress. But if it's a term baby and probably the distress is, the SAS score is between 0 to 3, then you do free flow. If it's moderate, then you start your CPAP immediately and monitor for response. Like Dr. Nora said, we are overwhelmed, like in Kawempe. Such a baby who had a SAS score of 8 definitely would have gone for ventilation. But before we even look at mechanical ventilation, what had we done for this baby? 1, the baby was hypothermic. 2, the baby was delivered and not moved on CPAP from labor suit. So there are certain other things that we probably missed out that may have made our prognosis or clinical course more later and more smoother than it was. Okay, so if it's severe, we go straight to mechanical ventilation. So this SAS score is very important because it has been validated. They compared some biochemical markers with the clinical judgment. And the studies have shown that actually when you do a SAS score, it speaks into what the oxygen of the perfusion is. Okay, so we look at the European consensus guidelines and then the American guidelines that recommend that actually by the time the baby has a SAS score of more than 6, then their FiO2 need is between 30 to 40%. Okay, so even without our blended oxygen or ability to actually do the FiO2, we can use our clinical judgment to cater for these babies without complicated things. So we prevent this approach, prevent where possible. We shall still talk about antenatal steroids, especially for anticipated preterm labor. And then we shall talk about skilled resuscitation at birth. It should be gentle. You should avoid aspiration. And above all, we should prevent hypothermia. Because with that, it's a strong start for any baby, preterm, term baby, it shall start. Then early CPAP in the delivery room. This one is being pushed everywhere where we don't have the already made CPAPs. We're advocating for the already made CPAPs. And how we don't have, we can do the improvised. And like he said, we should also learn how to make the improvised, and most of the healthcare workers actually know. So the other one is infection control, timely surfactant, and KMC. The moderator said that KMC is sometimes the only option we have to keep the babies warm. So let's do kangaroo mother care for as long as we are able to, as soon as possible, as soon as we are able to do that we control temperature. So we need to escalate these interventions early. If you started on oxygen therapy, maybe with free flow, look at your baby and escalate care as soon as possible. Of course, like we said, early CPAP in the delivery room for preterm babies, but for term babies, where you think your free flow is not working, escalate to CPAP as soon as possible. Then where we need to give surfactant, let's give it as early as possible, like we shall see. Where we have apnea and we are failing on CPAP, let's escalate to mechanical ventilation. Because if you do it early, then even the stay on the mechanical ventilation will be shorter. If you suspect sepsis, let's start the antibiotics as per guidelines. Now, antibiotics as per guidelines, our first line is ampicillin and gentamicin as per the clinical guidelines for Uganda. And our second line is cefotaxime, amikacin, usually used together. And then our third line is meropenem. So importantly, refer early if no improvement, or if you think your center cannot handle the increased work of breathing. So once a baby comes, Dr. Nora went through this. Once a baby comes, what do? You do the airway, the breathing, the circulation, the drugs, and the environment. And when you look at the airway, like I've said, 50% of the resistance in the airway is in the nasal passage. So the airway for preterms and the newborns, one is you can make it patent by just positioning, like he said. Positioning, there's what we call nesting that we always emphasize everywhere. When you nest, you give the baby a shoulder pad that makes lifts the chest a bit and puts the baby in a position to align the airway. Very important for preterms, because once the position is out of order, either overflexed or overextended, then there will be obstructive apnea and the baby will go into apnea. Okay, then the secretions, like our baby had secretions. You see the baby worsened, but when on examination, the baby had secretions. When we suctioned and then put baby back on CPAP, then it was okay. If you don't clear the airway and you put on CPAP, it will not work. And in the nursing care, when you put in CPAP, because oxygen sometimes is dry and cold, it causes crusting. So the baby is blocked. So your baby is on CPAP for 5 days, the nostril is blocked, and there is worsening distress. Just because the nostril is crusted. So we, as nursing part, we need to always open up the nostrils such that the babies don't have to be obstructed. Okay, so then of course airway, I'll talk about warmth in the next slide, but warmth is extremely important from the word go to the very end, through the whole course of management of a newborn. Keeping the baby warm and with a normal temperature is paramount and is important at every point. So breathing, we support the breathing. There should be effective ventilation. Effective ventilation means the air enters and the air comes out. So if it's inadequate, if it's inadequate, if the breathing is inadequate, then sometimes we augment with using PPV, depending. Maybe the baby is just born, or along the way the baby's breathing is not as spontaneous as it should be. Then we can do the PPV. So if breathing but moderate distress, we put the baby on CPAP, and this reduces the need for intubation. Like we've said, there are very few mechanical ventilators in Uganda. So we have to emphasize CPAP as much as possible. So we give oxygen, but we avoid high FiO2 where possible. For those who have blended oxygen in those higher centers, where possible. But for us in the lower centers, where we cannot blend, we look at benefit versus the risk. The benefit outweighs the risk. So we give what we have, okay? So in saturation, we look at, we need to maintain a normal heartbeat, because the lungs, the brain, the heart all work in conjunction to ensure that the baby is breathing well and getting well perfused. So one of the things that we actually do that is very simple is the capillary fill time. Very simple. Just press either the nail or somewhere where you can easily see that the blood returns within 2 seconds. It's very simple but important because it speaks into the saturation system, okay? Then the drugs, depending, we usually get an IV access for a baby who has respiratory distress, because we are thinking this baby is going to be admitted and definitely we are going to manage. So we shall get an access, take off a blood, but the most important investigation is the glucose. Because why? Glucose is the fuel. If you don't have glucose, truthfully, everything will fail, including the respiration. So the environment, I will not emphasize it any further. Thermal regulation is key. And then, most important, plan a referral. If NICU or higher level care is needed, referral as soon as possible. But before we refer, there is no rush for referring before stabilization. So we should stabilize the baby. Look at the airway, the breathing, the saturation, stabilize the baby before you push the baby to Kawempe. Don't push babies to Kawempe who are 30 degrees Celsius of temperature because you're rushing and you want to push sometimes the mortality elsewhere. So we stabilize the babies before we actually transfer them. So I'm going to spend a little bit time on hypothermia and hypoglycemia. Hypothermia, next slide. Hypothermia, hypothermia, we may take it lightly. The normal temperature for a newborn, for a baby, is 36.5 to 37.5. When you have 36.3, we should not be comfortable. When you have 35, we should not be comfortable because it speaks directly to what is going to happen to this baby's respiratory system if the temperatures are low. They say for every 1 degree fall in temperature, it contributes to about 10 to 15% of increased oxygen consumption. So when oxygen consumption is increased, and here we are struggling, the demand increases, yet the supply is low. So what will happen to this baby? They will try to compensate. They'll go into tachypnea, then increased work of breathing, then the cycle continues. Hypothermia causes pulmonary vascular constriction. When the vessels in the lungs constrict, what will happen? It means there will be a ventilation perfusion mismatch. The blood is here to take the oxygen, but the lungs, the alveoli are not open enough. The alveoli are open, but the blood vessels are constricted. So there will be a ventilation perfusion mismatch. That is just because of hypothermia. Then it will reduce the surfactant production by the pneumocytes, and it will also cause surfactant deactivation. Hypothermia, when it falls by 2, meaning if you're 30, if you're 34, if the baby is 34, then it will cause central respiratory depression, causing apneic spells. The other thing is chest wall rigidity. Once the baby is hypothermic, more than, meaning if you're like 33, 34, it will cause chest wall rigidity, which reduces the tidal volume, which reduces the ability of the chest to expand so that the air enters well. Then if it's above 3, that is below 34 degrees, then it will cause severe metabolic acidosis, which will lead to respiratory failure. I can't emphasize it anymore because hypothermia alone can make all the work that you have done disappear. Our baby had a temperature of 35, and I think the window to improve was a little bit, we delayed, I think, to improve our temperature, which probably also made the course very, very bumpy. So the other one is hypoglycemia. Hypoglycemia, that's why when you're looking at the number one thing that you can do is correcting hypoglycemia, because hypoglycemia alone, just alone, without any other cause, it causes apnea, it causes weakness of the muscles because glucose is the major fuel that produces ATP. ATP is energy. All the things that we do require energy. So once energy is depleted, either from the CNS, from the muscles, from wherever, then definitely they will go into respiratory distress. Now, hypoglycemia and hypothermia together, they shift the hemoglobin curve or the oxygen delivery curve to the left. This one is science a bit, but when the curve is shifted to the left, it means the hemoglobin latches on the oxygen and it will not release it. Once it doesn't release it, then we go into the cycle, continue, vicious cycle. Hypoxia, acidosis, then respiratory distress will not be, we shall not deal with it. So I want to encourage everyone that if there is anything you should take away from this, is hypothermia, which is very common. Almost all the babies we receive in Mulago from out, most of them are, and we usually want to communicate back and say, hypothermia, no. Before you transfer the baby, put access, give glucose, such that the baby has some glucose to run. So let's control hypothermia, let's control hypoglycemia, let's treat and manage, okay? So in 2 other things, Charlie has already talked about the CPAP and why it's very important. I will not repeat. So, but probably I want to say that it's only given where there is good respiratory drive. Some people just put CPAP, baby is not breathing, baby's breaths are shallow, and then you put CPAP. No, you should put CPAP in a baby who has a good respiratory drive, not just anyone, or to keep the baby alive as you do other things, as you go about, you put the baby on CPAP as you give the drugs for midday. No. That baby should have a good respiratory drive. Someone talked about CPAP, the different devices for CPAP. We have the bubble CPAP. This bubble CPAP, one can either be improvised or they're actually already made CPAPs. And I know most of the centers, some of the centers have these CPAPs. Some that improvised with our local materials, like we talked about, to make. And then some can be electric. Electric CPAPs is just electric, like you say. Electric, we plug into electricity, but it has other advantages that most of them have blended oxygen. Blended oxygen means you're not giving 100% oxygen. You can adjust actually the FiO2. You can adjust the liters of oxygen per minute. So it's better, and we think its pressures are better controlled and more effective than the bubble CPAP. Then you also have CPAP on the ventilators. The ventilators have a setting that can allow for you to give CPAP as you win from other modes of ventilation to the lower modes of ventilation. Yes, so surfactant. Surfactant, like we've said, surfactant is given in most of the higher centers and it's being provided by the ministry, and national medical stores actually provide surfactants for Kawempe, I think the national referrals and the regional referrals. So the question was how much surfactant was given. She explained it. The government has mainly Beractant, which is bovine, and it has, I think, two. There is Savanta, where we give at 100 milligrams per kilogram, which is equivalent to 4 mils per kilogram. Then the other one, the BLC, the bovine lung extract, is given at 5 mils per kilogram, which is equivalent to 135 milligrams per kilogram. So we usually early surfactant is given as a rescue, not prophylaxis. Okay, some places still practice prophylaxis, but we say we give where actually the baby has respiratory distress syndrome, because surfactant is very expensive and we cannot be giving it out to everyone. So if a baby comes and they are stable and they don't qualify for surfactant, we shouldn't. And also, giving surfactant is also, as much as it would be nice, but sometimes it also has its own disadvantages. One, I think the question was, how did we give? I think we usually use the ensure method, which is you intubate, you give the surfactant, then you extubate the baby to CPAP. Then also, I think Lisa method has been trained in some centers where it's less invasive. We just use some catheters. I think the bovine lung extract has those catheters that you put when the baby is still on CPAP. You just put and then you deliver without intubating, which limits the temptation to put on mechanical ventilation. So it's Lisa or ensure method. So we should give it as early as possible. The European consensus and the American Academy of Pediatrics and WHO recommends that we give surfactant within the first 1 to 2 hours. It's more effective because you have diagnosed that this baby actually has RDS and may need surfactant. Yes, let's rescue. These are the repeat doses. Sometimes we repeat the doses of surfactant. Some recommend up to 3 doses, some recommend up to 2 doses. So when you give the first dose and the baby doesn't improve, or there is an ongoing pathology that is causing surfactant deactivation, then we can give a second dose, preferably between 6 hours to 12 hours. Okay? Yes. So surfactant helps in oxygenation and opening up the lungs, that we don't have to take the baby to mechanical ventilation, which we do not have. So mechanical ventilation, if we have failed free flow oxygen, CPAP, now CPAP has failed, the only other support we have is, okay, there's another thing besides the CPAP, there's the high flow nasal catheters that are also effective and can be used either in place of CPAP or after CPAP, or some centers just use it even before the CPAP. So if those non-invasive ones have failed, we go to mechanical ventilation. And for centers that have mechanical ventilation, we encourage gentle lung protective ventilation modes. And we want to win to CPAP as soon as possible. Yes, so mechanical ventilation, we use it if the oxygenation has failed, that despite your interventions, you're remaining, that your SpO2 has remained low. So for the centers that are referring, when you look at your oxygen saturation and it's failing on CPAP, you need to refer sooner than later. So it also speaks to ventilation failure, that the body is retaining a lot of carbon dioxide. So it's only mechanical ventilation that helps. Then if there are recurrent apneas, or the baby's work of breathing was so much that the baby got exhausted and tired, or in any other instability like metabolic instabilities that may develop and need to be supported by mechanical ventilation. So if you have to remember anything, every breath in a newborn is precious, because if they do not breathe and push in that oxygen, then they will die. So we need to act, recognize distress early, support promptly, and at the back of your mind, you should know that it's a symptom, it's a sign, and you have to manage the underlying cause. So just a bit of differentials. As much as we are looking at, and we've looked mainly at pulmonary, respiratory, there are other things, because you're managing this baby, but you should know that maybe something else might be causing either the desaturation or the respiratory distress, which other than the lungs. So you look at every system. Usually it's the lungs, the heart, the brain. It could be structural or it could be metabolic. So, and some of the things are differentiated clinically. If it's cardiac cause, usually when you put the oxygen, it may not improve. If it's pulmonary cause, you put the oxygen and the baby will improve. So other causes besides cardiac, we have also CNS, and in CNS we have birth asphyxia, which is very common, or we have sepsis with meningitis. Then structural choanal atresia. If it's bilateral, definitely the baby will have severe distress. If it's unilateral, sometimes it can be moderate, and you may be confused with other things. So others like sepsis, anemia, severe anemia, we know it's the oxygen. The oxygen is carried by hemoglobin. So if you have low HB, definitely you'll have respiratory distress, because you're trying to compensate and carry more oxygen as much as possible. So just tackling to our 5, I'm going to be very fast, because I think I've approached the management almost awesomely. So RDS is respiratory distress syndrome, and this it speaks to surfactant deficiency. And it's mainly in the preterms. However, in some terms where we have meconium aspiration syndrome, pulmonary hemorrhage, or infants of diabetic mothers, their surfactant can also be deficient because of the activation by the different disease pathology. So RDS, surfactant deficiency, how do we manage? Early CPAP in the delivery room, transfer the babies on CPAP, such that CPAP is continuous positive airway pressure. It means it splits the airway open during inspiration and expiration. So if there is no surfactant and there is CPAP, it will keep that alveoli open, which is the job of the surfactant, which is very expensive. So we stick to CPAP. So that's RDS. So the next one is TTN. TTN is transient tachypnea of the newborn. And this one is mainly seen either in term babies or near term babies. And usually it's because the fluids in the lungs have not been removed. So like I've said, with this increased cesarean section, usually babies get respiratory distress, not because of anything, but because their fluids have not been given chance by the normal labor to remove the fluids. So that is TTN. So it usually resolves within 24 to 72 hours. Usually, unless there is an underlying cause, it will actually go. Some TTNs can be also difficult, especially if it's near term babies, because they can also present as if RDS. So the next one is meconium aspiration syndrome, which is usually meconium aspiration. It means, one, there is a history of meconium in the liquor, and there is a risk of babies aspirating. Usually babies swallow this meconium, and it's not dangerous. However, we admit them because, like I've said, when you aspirate meconium, it can either go in bulk and block, causing obstruction, or it may not be a block, but it might cause irritation, causing chemical pneumonitis, causing surfactant inactivation and causing distress. So sometimes it resolves within 48 hours. However, it can actually become very, very serious. And one of the feared complications is persistent pulmonary hypertension of the newborn. So when we have meconium aspiration syndrome and the baby is not improving, one of the things that we think about is persistent pulmonary hypertension of the newborn. All right, so that, yes, management is the same. Pneumonia, like we've said, if you look at the causes of respiratory distress, pneumonia usually, unless the baby is at risk of sepsis or something is probably causing in either early onset sepsis, usually it presents later. So it's of course bacterial or viral, but usually bacterial. And we usually do the septic screening and it guides that. So as with the septic screening, usually if there is a risk of infection, usually from or maybe fever in the mother during labor or chorioamnionitis, or maybe the mother's on medication like for UTI. So if there is that history, then we usually start prophylactically as we take off the screening tests. So that's what we have already talked about. Differentiating, I think so we have differentiated, especially these 5 things that we have talked about. We look at the feature, then the others. So if it's RDS, it's preterm. If it is meconium aspiration syndrome, you are looking at either term or post-term. If it is CTN, you're looking at cesarean section without labor. Pneumonia, usually anyone can get the pneumonia. Onset, RDS within minutes of delivery, minutes to hours of delivery. Meconium aspiration syndrome, it can be at birth or later on, depending on how much meconium you've aspirated. TTN usually is early. Pneumonia, anytime. Chest findings, the classical one, the major classical one is RDS, where it's ground glass appearance because of atelectasis. All the most of the alveoli are collapsed, so it will give you a whitening of the X-ray. So the main causes, we have talked about them. So to wrap up, I'll just talk about apnea of prematurity because it was one of the things. It's not directly pulmonary, but I'll just talk about it. So we know that when the baby stops breathing for more than 20 seconds or less than 20 seconds, but the baby desaturates and the baby desaturates and the heart rate goes down, like our baby. The baby got out of the blue, desaturated, went down. But we have seen that it was because the baby had secretions that they had to remove. But the fact that they stopped breathing, that is apnea. With desaturation, that is apnea. Okay? So it's the most common, it's common in the preterms and because of immaturity of the brain, of the respiratory muscles, and other things that put these babies at risk of respiratory distress, or respiratory depression. So usually there are types, like I've said, central apnea or obstructive or mixed. I want to emphasize obstructive apnea because central apnea, like Dr. Norris, we saw in our case, we gave caffeine. And sometimes we don't have a lot of control. Once we give the caffeine, if there's nothing else that is causing the central nervous depression, then we have no control. But for obstructive apnea, we have control because we can actually open the airway and relieve the obstruction. So the most common is the mixed type. It has a central part and then the obstructive part. I will not go into pathophysiology because at the end of the day, we manage the distress and we are good to go. So management, all the other things that we have talked about, plus caffeine citrate. And the caffeine citrate, like we have said, the guidelines show we start at a loading dose of 20 mils per kilogram, and then we maintain at 10 mils per kilogram. But when we have apnea, we also have to think about other possible causes of the apnea. One of the things is hypothermia. Very, 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 very key. You have your baby, they are stable before you know they're becoming apneic. You do the temperature and it's 34. So surely, these are the feasible things that we can actually handle to prevent apnea. Apnea is not good because once you cease to breathe, then you're giving the baby's brain an episode of hypoxia. So the longer these apneas are, the worse the brain injury. That's why when you have recurrent apneas, we would rather put on mechanical ventilation rather than trying to stimulate and keep the babies on CPAP. Yeah, so we usually give caffeine now to about 34 weeks, but with observation, you observe. If there is still clinical apneas, then we can sometimes push this caffeine to even more than 34 or 36 weeks. So our take home. So our key take home messages: one, let's support these babies as much as possible. Early CPAP saves lives. It prevents us from getting into mechanical ventilation, which we do not have. Then surfactant, it is selective, it's not routine. But of course, some people practice routine, but it's not routine. It's expensive and it should be given to the people who need it. Then we should avoid hypothermia. I can't emphasize it anymore. Hypothermia and hypoglycemia. We add antibiotics when sepsis is suspected. Preterm babies are not given prophylactic antibiotics. We look at the septic concerns and then we manage accordingly. Then lastly, refer early to higher centers when indicated and when needed. Thank you very much.
Thank you so much, Dr. Kezia. I think she has been elaborate and clear, and I believe we have picked a lot from her discussion. We so much appreciate. Thank you so much. Yeah. Yes. She has highlighted so many things, and I believe you've taken note of them. Yeah, just to add on a few things that I captured from her presentation, and I feel that are part of take-home messages. She talked about referring babies immediately, but I add on to what she has said, and I say that in case you suspect that the mother is having, is pregnant and is likely to give birth to a premature, make sure that you refer that mother to a setting where she will deliver and the baby will be taken care of without the need of transporting that baby to somewhere else. And then the other thing is an emphasis on bagging. Don't put the baby on CPAP if the baby is not breathing. Please bag the baby first until spontaneous breathing is established, and then you put the baby on CPAP. And then hypothermia. It's important to note that hypothermia is one of the signs of sepsis. So the baby might be cold, and then you put the baby on a warmer or on kangaroo, and you forget. Go back and check. If the temperature does not improve on kangaroo, please query sepsis. Those are the three things that I probably wanted to add on. Otherwise, we very much appreciate. And we are going to our next session where we are going to discuss, and then we'll be able to respond to questions. Yes. Okay. Thank you. Yes. So we are going to discuss and then be able to respond to questions. So already on our chat, there are so many questions. And I believe we've been trying to respond to some of them as we were going on, as the discussions were going on. And please, if your question is not answered, let us know by you raising your hand. So, well, there are some questions that are not responded to because they need a detailed explanation. And I would like to invite Dr. Tom to take on and address those questions. Thank you.
Thank you very much, moderator, and a very good evening again to our participants online. There were some questions that we couldn't give short answers, but there is some detailed explanation. One of the questions that was raised is, can you please elaborate on TTN? How long does it take? And so TTN basically is transient tachypnea of the newborn. It's a respiratory condition which arises due to delayed clearance of the lung fluid, and is common in term babies, and especially those ones who are born by cesarean section, and also babies born of mothers who have diabetes mellitus. And there is also a preponderance in male sex. Babies are more prone to TTN than female babies, as I will elaborate shortly. So what usually happens in normal, the contraction of the uterus squeezes out the fluid from the lungs, the thoracic cavity of the baby, and that fluid is the babies that are delivered by cesarean section do not have that time for the labor contractions to try to squeeze the thoracic cavity of the baby as it comes through the canal and squeeze out the fluid. That's why it's common when these babies are newly born, you find some fluid coming out of their mouth. It's just because of the fluid that was in the lungs that has been cleared. So when a baby is delivered by cesarean section, that process is not there usually, and the fluid remains within the lungs. And also there is what they call the catecholamine surge. The process of labor causes some stress on the baby, and you have some hormones that are released, the adrenaline and noradrenaline, and also cortisol released. So these are critical. They help in opening the sodium channels that help in the reabsorption of fluid within the lungs. So TTN is a condition essentially benign and is self-limiting. It resolves within a few hours, but can also take about 72 hours of life. So basically that is about the TTN. Then there was a question is that how do I warm up? How do I warm a preterm baby? So preterms are usually babies born before 37 weeks of gestation, and they are classified. There's a number of classifications. We have the extreme preterms. Those are the babies that are born below 28 weeks. Then you have the very preterm, 29 to 32, moderate preterm, 32 to 35, and then the late preterms. So depending on what age the baby is delivered from, and for extreme preterms, there are some constant things that you must ensure when you're delivering the baby. The environment, you have to manage the environment so that if the labor ward or the delivery place, the temperature should not be low. The temperature should be at least above 25 degrees centigrade. So when these extreme preterms are delivered, what we recommend, according to the current evidence, is they should be wrapped in a polythene. You don't dry them and put under a radiant warmer, and then that helps you to reduce on the heat loss and helps these babies to attain temperature. And then other modalities, of course, again, when they're receiving in the delivery room, you have to pre-warm the clothes or the sheets the equipment that you're going to use for covering these babies. You ensure that you warm the clothes, you warm even the equipment that you're using for examining these babies, they should be pre-warmed. And then the other ways you can warm up these babies is to put them in an incubator. Initially, we prefer the servo-controlled incubator, targeting a temperature between 36.5. We ideally, centers that deliver should at least have incubators in place so that these babies who may be born preterm ideally can be warmed in an incubator. And they're warmed gradually, increasing the temperature by about 0.5 degrees per hour. And then the radiant warmer, if you have a radiant warmer, you can use a radiant warmer for warming these babies, and you have to attach a temperature probe on their skin so that these babies are warm. Then the most important thing that can be applicable everywhere is the kangaroo mother care. KMC is one of the proven local strategies that helps to provide warmth to these babies at no cost. But this is basically for stable babies who may not be requiring other respiratory support. So by and large, so basically that's what I want. And then the feeding, you have to make sure that these babies are fed. Those ones are not breastfeeding. You have to ensure that they're given 10% dextrose to prevent hypoglycemia, which can also give hypothermia. So the other question, I think some of them were answered, and in case maybe the others are not yet answered, I'll be able to answer them in due course. Thank you, and back to you, Chair.
Thank you so much.
Oh, maybe there's one that I thought this is very, very important, that why do we combine an aminoglycoside and either penicillin or cephalosporin? So basically the rationale is to have wider broad spectrum coverage, because most of the causes of neonatal sepsis and infection in the newborn will have the gram positives and the gram negatives. So for aminoglycosides are more useful for the gram negatives, but the cephalosporins can cover gram negatives and also gram positives. And then the other thing is because of the risk, these babies, when they get sepsis, the bacteria multiply very fast with low resistance, they're prone to getting meningitis. So we want to give a medicine that can penetrate the blood-brain barrier. That's why in most cases we combine them so that we do not waste a lot of time, especially if you are not able to do cultures in time. And then the other thing is the synergistic effects. The cephalosporins act in destroy the cell wall, and then which increases the permeability or the aminoglycosides. So they have penetrating power to kill the organisms faster. The same thing with ampicillin and gentamicin, the same reasoning applies. And depending on the setting where you are, if you are still having organisms sensitive to ampicillin and gentamicin, that's the first line drug. And then you go into the second line drug. In most cases, it's cefotaxime and trimethoprim before you go to meropenem. But this largely depends on where you're practicing from. So I think some of the questions were answered, but in case there are other questions that were not answered, I should be able to the other one is on transfusion thresholds. I try to answer it. Usually we do what they call the restrictive blood transfusion strategy as opposed to the liberal one because of the other risks of blood transfusion. But according to the current evidence and most of the guidelines, the cutoff, if a child, a preterm is on a mechanical ventilator and the HB is 12 grams per deciliter and below, that preterm should be transfused. And this is really depending on the respiratory support these babies are having. So if the preterm or the baby is on CPAP, the cutoff point is usually 10 grams per deciliter. And then if the baby is stable and they are probably also having some other respiratory difficulty, but requiring free flow oxygen or no oxygen at all, usually we try to be conservative. We transfuse when the HB is less than 8 grams per deciliter. And again, these are just guidelines. It depends also the clinical presentation of the patient, because usually we transfuse patients, but we do not transfuse what? HB. Thank you, and back to you, Chair.
Thank you so much, Dr. Tom. Thank you for the responses to the answers. Yeah, I think our time is far much spent, I would like to respond to someone who wanted Dr. Nora to repeat the case presentation. Time won't allow. We would love to, but then time won't allow. So it's already attached to the chat, so you can download it and then take your time to look at it. Thank you so much. We are going to our last. Okay, I can see the hand is up. Mr. Edbert Bagasha.
Thank you very much for the presentation and all the presenters. I still have an inquiry about steroids. We usually have challenges that mothers come to us in late stages of labor and assuming that they're less than 32 weeks, and we don't have the chance of giving maybe 2 doses of betamethasone or the 4 doses of Dexa. So is there any use of steroids in a newborn themselves? Like, can you apply the steroids in a newborn?
Yes, thank you so much for the question. I would like to forward it to Dr. Kezia to give us the response to that question.
Thank you so much. Sometimes there's, of course, a temptation, the fact that we are saying if we use it in the mothers, why wouldn't we use it also in the baby? But the mechanism of action is really different, such that when we give it to the babies, it may not do what we need. So there is no clinical evidence to support the use of steroids in line with RDS to increase the surfactant production. So no, we don't use steroids postnatally. We encourage to give to the mothers, not the babies, specifically for RDS. Other diseases may be yes, but not for RDS. Thank you.
Thank you so much, Dr. Kezia, for that response. I believe Edbert is satisfied. Yeah, and so we go to the last session, where we are going to look at our questions again. And I'm going to request the technical team to post the questions. Okay. So we have our questions, the ones we answered when we were beginning the discussion. We are looking at them again and to see how we have responded. Now, I mean, you will see how the difference is what we are interested in. Thank you so much. You can respond to the questions quickly as we summarize up our discussion. So, thank you. So, as the technical team project the questions, I'm going to request the experts here to at least give one key thing that you want, a take-home message. Yeah, I would like to start with Dr. Nora.
Thank you so much, Dr. Olupot. So my take-home message would be when you receive a baby or maybe in the labor suit theater and this baby has distress, you should be quick to act. As Dr. Kezia has said, initiate the CPAP immediately if this baby is a preterm. And then also, as you're looking, do not have your mind fixed at only one thing. Look out for the different causes of respiratory distress as they have been discussed. It could probably be a cardiovascular defect, a congenital heart defect that is actually causing the respiratory distress. It could be the common things, hypothermia, hypoglycemia. So all in all, you're not supposed to have your mind fixed on only one thing. Address this baby in totality. It could actually also be coming from the abdomen. Maybe you have a congenital diaphragmatic hernia that is actually causing the distress. So really have a wide perspective of all the different possible causes of respiratory distress. Yes, and also clerk the patient. Take a good history. The mother's history always guides you on actually what is causing distress in this baby. All that is very much important. Thank you.
Thank you so much, Dr. Nora, for that important piece of information. I would like to ask to hand over the task to Mr. Andrew.
Yeah, thank you very much, Dr. Moses, for giving me the chance once more. Most importantly, to the nursing side, we are most of the time in position to be with these patients for a long time compared to our colleagues. So basically what we need to have at the back of our mind is that these things that we do, the interventions that we do are actually, sometimes they harm. It could be an intervention that its intention is to treat, but sometimes it can harm. So we need to have at the back of our mind that we need to keep doing those prognostic checks always. Because you will be managing the case, but you don't know that the CPAP actually that you've given is actually causing a problem. Like doctor said, it could be a theft, could be a coronary treasure or something like that, and then your CPAP is worsening the condition. Then I also need to encourage my fellow nurses in NICU. I know working in a NICU is not easy. That one I know it's not easy, but also don't be carried up by not knowing, and then you carry on with something you don't know. If you don't know, please ask. If you don't ask, then you have really caused problems. And if you ask, you have saved the money, you have saved time, you have saved the life actually. So please, if you don't know, ask, and don't fear to ask. And then many times we do a lot, but we don't document. Please, when you do whatever you've done, I know you've done a lot, please document. It is proof that you've done something. If you've not documented, then it means you've not done. Not documented, nothing done. Otherwise, if you maintain that line, then you will be good to go. Thank you very much.
Thank you so much, Mr. Andrew, for that powerful message. Documenting is very important. And I would also like to remind us that there's a link already posted for CPD points. As I invite Dr. Kezia to give her remarks.
Thank you very much. I will read I will just remind us that we are celebrating Prematurity Day on the 20th from Mbarara. And our theme is give preterm babies a strong start for a hopeful future. So I'm encouraging all of us that we actually try as much as possible to give a strong start, which includes early steroids for antenatal mothers with preterm labor, gentle resuscitation. Be gentle when you're in the labor. Don't bag and push all the air that is in the labor suit into the baby. And then we practice delayed cord clamping. We emphasize normal temperature between 36.5 to 37.5. Encourage KMC, kangaroo mother care, as soon as possible, and early CPAP. In a special way, I want to thank all of you who have been on call. It's a pleasure that we have had over 300 participants, people listening in from all over the country, people from Namalimba Health Center 4. We really appreciate, and God bless you.
Thank you so much, Dr. Kezia. We are concluding, but then it's the point now that we look at our questions. We look at our questions as we come to the end of this beautiful session. So the
moderator, I do also have something. I have something to say, if I'm permitted.
Yes, you're permitted. Go ahead.
Thank you, moderator, and again, a very good evening to all of you who have been in this meeting. So, as we celebrate the World Prematurity Day, I think we should be reflecting on is it really a day to celebrate? Because already we have numbers. We're having about 14, for every 1,000, there are 14 preterm births. It's good for us to celebrate, but prematurity is associated with a lot of complications. And what we should be looking at now at all levels is how do we prevent premature birth? So that as we celebrate with smaller numbers. So my message to all of us, both at the community and also the frontline health workers, is to ensure that we try to prevent premature birth. And prevention covers a lot of, it has multi-factor, it has a lot of ways that we can prevent. First of all, we need to prevent teenage pregnancies. So all of us, as we celebrate the World Prematurity Day, we should pass on a message to our communities that we should prevent teenage pregnancies, which are a risk factor to premature birth. And then we need to, when the mother or the ladies get pregnant, we should also emphasize risk identification during antenatal period, so that the maternal infections are identified, the risk conditions like hypertension, diabetes are managed well during the antenatal period. Then, of course, to strengthen the management of these babies when they are delivered, as has already been described. So I really request all of us to be advocates to prevent premature birth, and where they occur, we should be able to do the low-cost strategies that have been proven to ensure that they are given a chance. Thank you very much, and back to you, Chair.
Thank you so much, Doctor. My apologies that I might a little bit skipped, but then thank you so much that you came in and were able to give us that powerful message. Yeah, well, come to the end. Questions are already being answered. And as we conclude, I'm going to request Dr. Kezia to take us through the questions one by one. Yes. Oh, you can, they're already there. You don't see clearly.
Okay, number one, which of the following best defines respiratory distress in a newborn? So the answer was, just a minute, sorry. Sorry about that. I was revising my notes to ensure that they give the correct answers. So, which of the following best defines respiratory distress in a newborn? So the answer was any breathing abnormalities with grunting, nasal flaring, or chest indrawing. That was it. Then the next is a term baby delivered by elective cesarean section develops tachypnea within 2 hours of birth. The most likely diagnosis would be transient tachypnea of the newborn. Then the next question was, which of the following attributes is the primary cause of respiratory distress in newborns? Respiratory distress syndrome. So our answer was surfactant deficiency. Which of the following would suggest a diagnosis of meconium aspiration syndrome? And the answer is history of meconium stained amniotic fluid. Then the last one was the following are the important steps in handling a neonate with respiratory distress. So the answer was all the above, meaning we look at the warmth, the severity assessment, and the treating the underlying cause, so all the above. And I see the improvement was so tremendous. So we thank you so much for showing interest and being attentive in class. Thank you.
Thank you so much, Dr. Kezia, for leading us through the questions. And thank you, everyone, for your interest in this session and also attempting the questions and your very good responses. Now we are going to we want to see your videos. We want to see you on the screen. So turn on your videos. Turn on your videos. We want to see you. Thank you, thank you, thank you, thank you.
Do I know?
You never.
Yes.
I think was on
Yeah.
Kazi.
Yeah.
Thank you. Thank you
Thank
very
you so
much.
much.
You
Yeah,
do you have any people from outside Uganda?
yeah, thank you.
Outside Uganda, and is looking for
Anyone outside Uganda? Say hi.